You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about diastolic function and diastolic dysfunction. This topic is one of the most difficult in all of the episodes, so please don't get discouraged if you do not understand. It may take a few listens, and it's also a relatively long episode. We'll talk about E and A waves, the big E to small e prime ratio on tissue Doppler imaging, the SD and AR waves on PW imaging of the pulmonary veins, the isovolumic relaxation time, grading diastolic dysfunction in patients with normal versus abnormal ejection fraction, LA reservoir strain, assessing diastolic function and atrial fibrillation, diastolic stress tests, and miscellaneous diastolic facts. So let's start off with diastolic function. What is diastole? Diastole is the period from the aortic valve closure, end systole, to mitral valve closure, end diastole. The isovolumic contraction time, or IVCT, which is the period from mitral valve closure to aortic valve opening, is part of systole, whereas the isovolumic relaxation time, IVRT, which is the period from aortic valve closure to mitral valve opening, is part of diastole. During the isovolumic contraction time, the LV pressure rises rapidly. During the isovolumic relaxation, LV pressure declines rapidly. Diastole contains of 4 phases: isovolumic relaxation, early rapid diastolic filling, diastasis, and late diastolic filling caused by atrial contraction or atrial kick. First, isovolumic relaxation starts with the aortic valve closure, followed by a rapid decline in left ventricular pressure. When the left ventricular pressure falls below the left atrial pressure, the mitral valve is allowed to open, which ends the isovolumic relaxation period. Second, mitral valve opening allows rapid early diastolic filling. Third, as the ventricle fills, the pressures in the left ventricle and left atrium equalize, resulting in a period of diastasis, during which there is not much movement in blood from the left atrium to the left ventricle. Diastasis lasts longer at slow heart rates and is entirely absent at fast heart rates. Fourth, when atrial contraction occurs, left atrial pressure once again exceeds left ventricular pressure, resulting in further mitral leaflet opening and a second pulse of left ventricular filling, accounting for 20% of total ventricular filling. When you PW Doppler the tip of the mitral leaflets in diastole to assess mitral inflow in A4C view, you will see 2 mountain peaks corresponding to 2 pulses of blood rushing in from the left atrium to the left ventricle. The big E velocity reflects early rapid filling, followed by a relatively flat line of diastasis where there is little or no flow from the left atrium to the left ventricle. The big A velocity is late diastolic filling caused by atrial contraction. Let's talk about the normal E and A wave. This refers to big E and big A. The normal big E wave is the peak early filling velocity in meters per second. It is a reflection of the peak gradient between LA and LV pressure during diastole. The E wave is influenced by the LA pressure at mitral valve opening, the minimal LV diastolic pressure, the compliance of the LA, and the rate of LV relaxation. The time it takes the E wave to return to the zero line, i.e. the time it takes for the peak early filling velocity to return to zero, is the deceleration time, measured in milliseconds. After a period of diastasis, the A wave occurs, the filling velocity at atrial contraction. The A wave is influenced by LV chamber compliance and the volume and contractility of the LA. In a normal middle-aged subject, the E velocity is slightly taller than the A velocity, and the deceleration time is around 200 milliseconds, plus or minus 40 milliseconds. Now that we have this baseline understanding of diastolic function, we can go on to tackle diastolic dysfunction. If you are not sitting for the echo boards, you could ignore the rest of this podcast pretty safely, but if you are taking the echo boards, I encourage you to listen on. We'll start with talking about E and A waves. With increasing diastolic dysfunction, the E and A waves will flip in height, flip back again, and then the E rises sharply. Notice that an E to A ratio of at least 0.8 could indicate either a normal or pseudonormal pattern. To uncover a pseudonormal LV diastolic filling pattern, you can use the Valsalva maneuver, or you can do TDI of the septum or lateral basal wall, or pulmonary vein PW Doppler. We will now go over the reason E and A waves look the way they do at each stage of diastolic dysfunction. We'll start with mild, which is impaired relaxation, mild diastolic dysfunction. Grade 1, or mild diastolic dysfunction, is a state of impaired relaxation. The A wave becomes taller than the E wave, resulting in an E to A ratio less than 0.8. This is because the LV early diastolic pressure decreases at a slower rate, such that the duration of relaxation is prolonged from early diastole into mid or even late diastole. Assuming that LA pressure is not elevated for some other reason, the early diastolic driving force across the mitral valve is reduced, since the gradient between the left atrium and left ventricle is small. That is why the E wave is low, less than 50 centimeters per second. Since the volume is still sitting in the left atrium, i.e. there is a high residual atrial preload, the atrial kick sends a greater than usual amount of volume from the left atrium to the left ventricle, as reflected by the taller A wave. The E wave deceleration time is going to be prolonged more than 200 milliseconds because the LV early diastolic pressure is decreasing at a slower rate, and it takes longer for the LA and LV pressures to equilibrate. Next, we have moderate diastolic dysfunction, also known as pseudonormal pattern. Grade 2, moderate diastolic dysfunction, is pseudonormal. As diastolic dysfunction worsens, there is a progressive decrease in the left ventricular compliance, resulting in higher mean left ventricle and left atrial diastolic pressures, whereas in grade 1 diastolic dysfunction, only left ventricular diastolic pressure was elevated. Although left ventricular early diastolic pressure still decreases at a slowed rate as described in grade 1 diastolic dysfunction, this time, since the left atrial pressure is also elevated at the time of mitral valve opening, there will now be a large left atrium to left ventricle gradient in early diastole, thus producing a high E wave, shortened E wave deceleration time back to 150 to 200 milliseconds, mimicking the normal E wave deceleration time, and a higher E to A ratio of 0.8 to 2.0, mimicking the normal E to A ratio. To figure out if this E to A ratio of 0.8 to 2.0 is normal or pseudonormal, you can use tissue Doppler imaging of the septum or lateral basal wall, pulmonary vein PW, or ask the patient to Valsalva, which drops the preload. If Valsalva is able to drop the E to A ratio by 50%, that is highly specific for a pseudonormal filling pattern. Next, we have severe or restrictive filling. Grade 3, or severe diastolic dysfunction, is a state of restrictive filling. The E wave becomes extremely high, with E to A ratio exceeding 2 inclusive, because there is markedly elevated left atrial pressure. The deceleration time is shortened to less than 150 milliseconds. Note that although deceleration time was initially prolonged in grade 1 diastolic dysfunction due to left ventricle early diastolic pressure decreasing at a slower rate, in grade 3 diastolic dysfunction, the markedly elevated left atrial pressure reigns, and the LA-LV pressure gradient produces a tall E wave, that's an E to A ratio of at least 2 or higher, and a shortened deceleration time, less than 150 milliseconds. Now, let's take a dive into the physiology. The progression of diastolic dysfunction involves dysfunction in ventricular relaxation, chamber compliance, and filling pressures. First, we will talk about decrease in ventricular relaxation. Abnormal LV relaxation results in prolongation of the isovolumic relaxation time, a slower rate of decline in the ventricular pressure, that's a reduced negative dp/dt, and a consequent reduction in the early peak filling rate, that's a reduced E, due to a smaller pressure difference between LA and LV when the mitral valve opens. You also have decreased ventricular compliance. Compliance is the ratio of change in volume to change in pressure. That's a dV over dP. Stiffness is the inverse of compliance. That's dP over dV. When there is reduced LV compliance, i.e. increased LV stiffness, the curve on the pressure by volume plot shifts to the left. As LV volume fills in diastole, pressure rises abnormally rapidly, resulting in an initial high LA to LV pressure gradient, that's a taller E, with a shortened isovolumic relaxation time, a steep deceleration slope, and a reduced A velocity. You also have increased filling pressures. Elevated LV diastolic pressures is reflected as elevated LA diastolic pressures. LA filling from the pulmonary veins involves a small reversal of flow back into the pulmonary veins following the atrial contraction, that A wave. A systolic filling phase that is positive, a blunting of flow or a brief reversal at the end systole, that's the V wave, and a diastolic filling phase that is positive. In normal individuals, the systolic and diastolic filling phases are almost equal in volume. Now that we understand the stages of pathology, let's revisit the normal E and A wave and the normal variance it can have. There are slight differences in how the E and A wave look with respect to respiration, heart rate, PR interval, and age. Let's start with variation in heart rate. At higher heart rate, diastole is shorter and diastasis is abridged, often to the point that diastasis disappears. When the A wave is brought forward so much due to disappearance of diastasis, the A wave velocity is added to the E velocity before the E velocity returns to zero, resulting in a higher A velocity and a lower E to A ratio. A longer PR interval also causes A velocity to move earlier in diastole and superimpose on the E velocity curve. At extremely high heart rates, the E and A velocity curves become merged into a single EA velocity. In contrast, at slower heart rates, a diastole is longer, diastasis is longer, and the A wave comes later and tends to be shorter than the default A wave. How about variation with age? In children and young adults, most LV filling occurs in diastole, so the E velocity is prominent and only less than 20% of total volume comes from atrial contraction from the A wave. As individuals get older, the E velocity diminishes and the atrial contribution becomes more prominent, up to 40%, with equalization of the E and A velocities at 50 years old and reversal of the E to A ratio after 50 years old. Early diastolic deceleration time and isovolumic relaxation time both get prolonged with age. This is due to gradual reduction in the rate of early diastolic relaxation as individuals get older. Since E velocity and E to A ratio is supposed to decrease with age, if you find a quote normal LV filling pattern in an elderly patient, meaning an E to A ratio of at least 0.8 up to 2.0, you need to still suspect abnormal ventricular compliance. Next, how about variation in preload? Increased LA pressure due to increased preload results in an increase in the E early diastolic velocity because there is more stuff that needs to be ejected from the LA to the LV, a shortened isovolumic relaxation time, and a steeper deceleration slope of early diastolic filling. Conversely, reduced LA pressure due to decreased preload results in a decrease in the E early diastolic velocity because the gradient between LA and LV at mitral valve opening is smaller. Note, you can ask the patient to Valsalva transiently to decrease the preload to see the effect. When there is sinus tachycardia or first-degree AV block, i.e. prolonged PR interval, you can't use the E and A waves and the E to A ratio to assess diastolic function because these conditions can result in partial or complete fusion of the E and A waves. What if you see another little peak between the tall E wave and the short A wave of the mitral inflow PW Doppler? That is called the L wave, a mid-diastolic flow across the mitral valve. The L wave represents continued pulmonary vein mid-diastolic flow through the left atrium into the LV across the mitral valve after early rapid filling. Triphasic mitral inflow in patients with LV systolic dysfunction is associated with clinical heart failure. Triphasic mitral inflow in patients with normal LVEF but LV hypertrophy is associated with elevated LV filling pressures and high risk of hospitalization for heart failure. Now let's move on to the second parameter for diastolic dysfunction. That's the big E to small e prime ratio, which I will here on refer to as just the E to E prime ratio. This is measured on TDI of the basal segment of the septal and lateral wall in A4C. Since big E is the peak early diastolic filling velocity measured by PW Doppler at the mitral inflow area, which is a measure of both LA pressure and LV early diastolic relaxation, and small e prime is the mitral annular relaxation velocity measured by tissue Doppler imaging of the basal, septal, or lateral wall, which is primarily a measure of early diastolic relaxation. Dividing the big E velocity by the small e prime velocity provides an estimate of LA pressure, since that is what's left in the numerator once you divide LA pressure and LV early diastolic relaxation by the early diastolic relaxation. Remember that on mitral annular tissue Doppler imaging, the S prime is upward and the E prime and A prime is downward. So E prime is the first downward trough. So make sure not to accidentally select the upward S prime. You want the downward E prime. A small little e prime has a lower cutoff at the septal annulus of 7 centimeters per second than at the lateral annulus of 10 centimeters per second, which makes sense since the lateral wall moves more than the septal wall at baseline. Since the small e prime has a lower cutoff at the septal annulus than at the lateral annulus, and the small e prime is in the denominator, big E to small e prime has a slightly higher cutoff at the septal annulus of 15 than at the lateral annulus of 13. Big E to E prime is considered abnormal if the average E to E prime ratio is more than 14, or the septal E to E prime ratio is more than 15, or the lateral E to E prime ratio is more than 13. Normal E to E prime ratio is 10 or less. Mild diastolic dysfunction may also have E to E prime ratio of 10 or less, but moderate diastolic dysfunction will have E to E prime ratio of 10 to 14, and severe diastolic dysfunction will have E to E prime ratio of higher than 14. Please note that the E to E prime ratio is not reliable if there are conditions that alter early diastolic transmitral flow, that's the big E, such as significant mitral regurgitation or mitral stenosis or previous mitral valve replacement, or conditions that alter early mitral annular relaxation, that's the small e prime, such as pericardial disease. The small e prime velocity is not completely independent of loading conditions, but it is much less dependent on loading conditions than is the transmitral E wave velocity that we talked about just now. As you diurese somebody with diastolic dysfunction, the small e prime should remain fixed, but the big E will improve, meaning it will come down. Therefore, the big E to small e prime will also improve. It will come down as well. The TR velocity will also come down. When is it invalid to use the big E to small e prime for estimating early diastolic dysfunction? Anytime one uses data from isolated regions of myocardium and tries to generalize results to the entire heart, a source of error is introduced if there are regional variations in myocardial function. If there is an old infarction in the basal septum, small e prime may be abnormally low, yielding an abnormally high big E to small e prime ratio. Since any prosthetic valve is inherently stenotic compared to the native valve which it replaced, the mitral E velocity will be raised, again increasing the big E to small e prime ratio. The small e prime velocity will be lowered. Similarly, mitral E velocity will be elevated in patients with rheumatic mitral stenosis. Aortic stenosis, on the other hand, should not have any effect on the use of big E to small e prime to estimate LV filling pressures. Now we've gone over E and A waves, and we've gone over the big E to small e prime ratio on TD imaging. We will now move on to the pulmonary veins, the S, D, and AR waves on PW Doppler of the pulmonary veins. S is the peak systolic velocity, D is the peak diastolic velocity, and AR refers to atrial reversal wave time, A of the pulmonary vein, when you do this PW Doppler of the pulmonary veins in A4C view. This is the apical four-chamber view. In healthy individuals, Forward systolic and forward diastolic flow velocities have approximately equal magnitude, with tiny, short, low velocity flow reversal into the pulmonary veins after atrial contraction, known as the atrial reversal wave. There are 4 components of pulmonary venous flow: 3 upright forward flow and 1 downward reverse flow. S1 represents early systolic flow due to atrial relaxation and apical displacement of the mitral valve. Left atrial relaxation will affect S1, not S2. S2, which is shorter in height than S1, represents late systolic flow from increasing pulmonary pressure related to right ventricular contraction and the right heart's output. Left atrial pressure affects S2, not S1. RV systolic function affects S2, not S1. And LV long axis shorten affects S2, not S1. Then you have diastolic flow, D, which occurs when the mitral valve opens and empties the volume into the left ventricle. Finally, there is a mild reverse flow from the left atrium back into the pulmonary vein, the atrial flow, A, which occurs because of atrial contraction. If you have predominantly systolic forward flow in your pulmonary veins, you almost certainly have normal left atrial pressure, because that indicates either a normal or mild diastolic pattern. Moderate and severe diastolic function would have both predominant diastolic pulmonary vein inflow. Why is S greater than D in mild diastolic dysfunction? Because of impaired LV relaxation causing impaired LV filling, the LA increases its reservoir function by stocking up volume during systole, hence increased pulmonary S wave, and the LA forces the volume into the LV using a more forceful atrial contraction. Hence, the A wave exceeds the E wave on mitral inflow. In mild diastolic dysfunction, the S hump exceeds the size and the height of the D hump, but as diastolic dysfunction progresses to moderate and severe, the S hump diminishes and the D hump grows. Why does atrial reversal flow in the pulmonary vein increase in moderate and severe diastolic dysfunction? Because the LV end diastolic pressure and LV impedance has risen to high levels upon LA atrial contraction, it forces reverse flow into the pulmonary veins rather than forward transmitral flow. Sometimes this augmented reverse flow may manifest as a greater velocity of PVA, but it more reliably manifests as a greater flow duration of PVA. Atrial reversal wave time less than 35 milliseconds is normal or mild, while more than 35 milliseconds is moderate. Thus, this is another way to distinguish pseudonormal from normal E and A waves. Pseudonormal state will have pulmonary Doppler imaging of the pulmonary vein demonstrating A wave reversal of increased duration more than 35 milliseconds and increased velocity. Severe diastolic dysfunction can be distinguished from moderate by having a pulmonary vein atrial reversal duration, ADUR, that is at least 30 milliseconds greater than the transmitral atrial flow duration, big ADUR. Small ADUR minus big ADUR, at least 30 milliseconds, so that's the pulmonary vein atrial reversal duration minus the transmitral atrial flow duration, more than 30 milliseconds inclusive, has a high sensitivity and specificity for having an LV end diastolic pressure more than 20 millimeters of mercury. This is accurate even in patients with MR or HCM, but it is invalid in heart failure, heart block, and other causes of E to A fusion. Now that we've understood SD and AR waves on PW of pulmonary veins, let's move on to the fourth parameter for diastolic dysfunction, the isovolumic relaxation time, or IVRT. As mentioned in the introduction, this is the interval after the aortic valve closure and before mitral valve opening. Using the apical 5-chamber view, apply PW Doppler at a 3 to 5 millimeter sample volume midway between the aortic and mitral valves to obtain a clear signal that shows both aortic outflow and mitral inflow. The IVRT is the time interval in milliseconds from the middle of the aortic closure click to the onset of mitral flow, or in other words, the interval from the end of the down hump to the start of the up hump. A normal IVRT is 50 to 100. Impaired relaxation, as seen in grade 1 or mild diastolic dysfunction, has prolonged IVRT at least 100 milliseconds. In contrast, elevated filling pressures and decreased compliance, as seen in grade 2 and 3, or moderate and severe diastolic dysfunction, have shortened isovolumic relaxation time to 60 to 100 milliseconds and less than 60 milliseconds, respectively. Note that IVRT is a useful piece of information, but is not officially part of the ASE, American Society of Echo, algorithm for classifying severity of diastolic dysfunction. Now, let's go over a systematic framework for grading diastolic dysfunction in patients with normal EF versus abnormal EF. In this scenario, they define EF of 50% and higher as normal EF and less than 50% as abnormal EF. In patients with EF of 50% and higher, the algorithm for grading diastolic dysfunction is very easy. It is just a list, it's not a flowchart. Is the big E to small e prime higher than 14? Is the septal small e prime velocity less than 7 centimeters per second or the lateral e prime velocity less than 10 centimeters per second? Is the tricuspid regurgitant velocity more than 2.8 meters per second, indicating increased systolic pulmonary artery pressure? Is the left atrium enlarged with LA volume index more than 34 milliliters per meter square? If more than half of the questions are positive, then there is diastolic dysfunction. So if 3 out of 4 or 4 out of 4 of these questions are positive, that's diastolic dysfunction. Then what about for patients with abnormal EF? In patients without normal EF, you then need to look at the big E to A ratio and the peak big E wave velocity. There are two easy cases. If the E to A ratio is 0.8 or lower, and the peak E wave velocity is within 50 centimeters per second, then it is grade 1 diastolic dysfunction and normal left atrial pressure. If the E to A ratio is exceeding 2 inclusive, then it is grade 3 diastolic dysfunction and increased LA pressure. However, if the E to A ratio is between 0.8 and 2, or the E to A ratio is within 0.8 but accompanied by a peak E wave velocity exceeding 50 meters per second, then you need to break the tie by looking at 3 of the criteria that we use for the normal EF patients. 1 is the big E to small e prime higher than 14. 2 is the TR velocity more than 2.8 meters per second, indicating increased systolic PA pressure. 3 is the left atrium enlarged with LA volume index more than 34 milliliters per meter square. If more than half of these questions are positive, meaning 2 out of 3 or 3 out of 3, then it is grade 2 diastolic dysfunction and increased LA pressure. If more than half of the questions are negative, meaning 2 out of 3 or 3 out of 3 are negative, then it is grade 1 diastolic dysfunction and normal LA pressure. If only 2 criteria are available out of the 3, and 1 is positive and 1 is negative, then you cannot determine LA pressure or grade the diastolic dysfunction. So that is the systematic approach of grading diastolic dysfunction in patients with normal versus abnormal EF. If you take away nothing else from this episode, these 2 sections that I just told you about is the most important. Now, I want to briefly touch upon LA reservoir strain. LA reservoir strain is used as a tiebreaker when you have a conflict in the other variables. For example, if only 2 criteria among the big E to small e prime ratio, TR velocity, and left atrial volume are available, and 1 is positive and 1 is negative. The European guidelines say to use the LA reservoir strain less than 18% as abnormal, which is very specific but poorly sensitive. The Mayo Clinic lectures say to use LA reservoir strain less than 24% as abnormal. Normal, for reference, is 40% LA reservoir strain. That's all I'll say about LA reservoir strain. Now, a very common question comes up, which is how do you assess diastolic dysfunction in atrial fibrillation? The bigger question is, when do you have to use alternative methods for assessing diastolic dysfunction in general? Well, when there is a mitral or aortic prosthesis or severe annular calcification, the motion of calcium or metal is not the same as tissue, so you can't use your E prime velocity, your small e prime velocity. If you have an aortic prosthesis instead of a mitral prosthesis, you can still use the lateral annulus small e prime, but you can't use the septal annulus small e prime. When there is significant mitral stenosis or regurgitation, You can't, because they all have elevated filling pressures regardless of whether they have diastolic dysfunction. When there's left bundle branch block, when there's tachycardia, or when there's atrial fibrillation, you all need to use alternative methods for assessing diastolic dysfunction. Focusing on the atrial fibrillation situation, since that's very common. Since LA volume is almost always increased in patients with atrial fibrillation, even in patients with normal filling pressure, left atrial volume cannot be used as a marker for increased filling pressures in patients with atrial fibrillation. There is no organized atrial contraction or A wave in the setting of atrial fibrillation, so there cannot even be an E to A ratio. AFib can result in beat to beat variation in E and E prime values, and thus you have to take the mean of several cardiac cycles and to use matched RR intervals for both big E and small E prime velocities. In patients with AFib, E to small E prime velocity, that is 11 or more instead of the usual 14 or more, is considered to be indicated of elevated left atrial pressure. However, while a septal E to E prime ratio more than 14 is suggestive of increased filling pressure, a lower E to E prime ratio than 11 can be seen with either normal or increased filling pressure. So septal E to E prime ratio has poor negative predictive value for increased filling pressure in AFib. Mitral deceleration time less than 160 milliseconds is also reasonably accurate for predicting increased LV diastolic pressures in AFib. Other Doppler measurements that indicate abnormal diastolic filling pressures in AFib are a peak acceleration rate of the mitral E velocity exceeding 1900 centimeters per second square inclusive, the deceleration time of the pulmonary venous diastolic velocity within 220 milliseconds, mitral E to VP of at least 0.4, that's the ratio of the left ventricular peak E wave velocity to flow propagation velocity as assessed by color and mode Doppler. And it is okay to use IVRT less than 65 milliseconds as an indicator for increased filling pressure in AFib. That is what I have to say for assessing diastolic function in AFib. We'll end with a section on diastolic stress tests. This is a pretty niche subject, but also worth knowing. If someone has exertional dyspnea from HFpEF, but resting diastolic function parameters are inadequate, and you still suspect the dyspnea is from diastolic dysfunction, you can do a special kind of exercise testing. Diastolic dysfunction on exercise is indicated by one of the three. An increase in the E to E prime ratio to more than 15, some people say more than 13, a decrease in the small E prime value, a significant increase in tricuspid regurgitation velocity. That suggests exercise-induced pulmonary hypertension, which may be related to LV filling pressures. The upper normal of exercise right ventricular systolic pressure is 50 to 55 millimeters of mercury. In otherwise healthy patients undergoing exercise echocardiography for a diastolic function assessment, i.e. a diastolic stress test, expected findings suggesting normal diastolic function include increases in the mitral inflow E and A velocities, increase in the annular tissue Doppler velocities, decrease in the mitral inflow deceleration time, no significant change in the big E to small E prime ratio, and no significant change in the tricuspid regurgitation velocity. Again, on diastolic stress tests, diastolic dysfunction and exercise is indicated by the three things: an increase in the E to E prime ratio more than 15, a decrease in the small E prime, and a significant increase in the tricuspid regurgitation velocity on exercise, which suggests exercise-induced pulmonary hypertension. That is everything for diastolic function and diastolic dysfunction. We've gone over the use of the E to A ratio, the E to A waves, the E to E prime ratio, S, D, and AR on PW Doppler of pulmonary veins, isovolumic relaxation time, grading diastolic dysfunction in patients with normal EF, and grading this diastolic dysfunction in patients with abnormal EF, LA reservoir strain, and assessing diastolic function in AFib. Let me say all of that again. We've gone through a lot in this episode. First, we talked about normal diastolic function and the four components of diastole. Then we talked about the parameters for diastolic dysfunction, E and A waves, the E to E prime ratio, SD and AR on PW Doppler pulmonary veins, isovolumic relaxation time. Then we went over a systematic framework for grading diastolic function in patients with normal EF versus abnormal EF according to the current ASE guidelines. We touched upon LA reservoir strain, and we talked about assessing diastolic function in AFib and diastolic stress tests. This is an extremely challenging episode, one of the hardest, if not the hardest, in this chapter and in the entire series. So thank you very much for bearing with me. And if it helps you, there are study materials available to correspond to this episode on my website. Thank you.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.